When I walked around the meeting this weekend, I started to look at all the things that were available to us, right? Skin scanning, different vitamins, different supplements, different things. You know, we have to make decisions on what we're going to do for our patients and what we're going to do on our patients. And we can't do everything, right? We can't do all the tests. We can't draw blood at new patient exams. We can't do all these different things because it's overwhelming, right? It can be overwhelming for the patient, so we have to decide what to do. We'll talk about that because I'm very, very passionate about one thing that we have to do in periodontal medicine. That's test for the microbial load or balance. And what are we going to do about that? Through this presentation, I'm going to talk to you a little bit about oral DNA and what oral DNA is about, what they're set up to do, and why I think oral DNA is the best company, the absolute best company that's positioned for the future to bring important saliva information to us. The company's well set up. It has a big medical side, it has a dental side, and it has some sophisticated and sharp people at the helm that are helping us make decisions about what kind of data we collect. So today I'm going to talk about the application of molecular and salivary diagnostics in practice, and a little bit about the lab. This is a presentation totally sponsored by Oral DNA, as you know, so that should come as no surprise. And then a little bit about oral cancer. And what I wanted to do, and actually I was talking with Dan the other night at a restaurant, and some of us have a hard time getting used to talking to our patients about this disease. And I'm talking about periodontal disease. And a good idea, and something that I started to do a long time ago, is figure out what's your shtick or how you're going to talk to your patients, then start practicing on your well patients. And what I mean by that is don't practice your first disease discussion on a diseased patient. Practice on your well patient, and it goes something like this. Hey Joe, your periodontal health is wonderful. What do you do? He'll tell you, well, I brush, I floss, whatever it is. I go, that's very cool, because you know there's some new information out about how gum disease really affects people's heart. I mean, here you go. Now you start listening to yourself, and you perfect that conversation, because that's the exact same conversation that you have when the next guy comes in and he's bleeding all over the place, and you say, you know, you're bleeding more than I'm comfortable with, and it's not normal. Because then they say, what do you mean it's not normal? And there you go. So practice on your well patients. Thanks for reminding me, Dan, to talk about that. It's been a huge, huge thing in our practice for us to get comfortable. How many people in the room are using salivary diagnostics already? Beautiful. And I know that we have Philadelphia, Ohio, I'm Michigan. We know it works on the East Coast anyways, right, in the Midwest. So we need to get everybody on board doing that. And then some of the problems in the office that I've heard about this morning are we don't retest, we don't do it enough. But here's one of the things that I haven't heard. Nobody said the patients say no. The patients might say no to treatment, but they don't say no to the idea of finding out what's driving the disease. Another tip or hint before we get too far into this is I don't like to do a lot of diagnostics on patients that I don't think will even remotely accept treatment. So you might do something like this. You might say, you know, Joe, treatment for this kind of disease in our office can range anywhere from $1,500 to $4,000. And they're going to say one of two things. Oh my God, I could never spend $1,000. Or they'll say, oh, thank God. I thought it was going to be 10. Right? So you find out a little bit about where they are before you start adding on the data. Dr. Coyce talks about a great story, and he runs a teaching institute in Seattle. He talks about a great story with a patient that he presented a large treatment plan to. So he tells this lady who runs a pizza parlor, who sweeps the floor in a pizza parlor, he says, the case is going to be $10,000. And he's thinking in his mind, there's no way she's going to be able to afford $10,000. And she says, well, you know, I've been waiting all my life to have my teeth restored. My aunt died, and she left me a whole lot of money, and I can't wait. And he said, well, it's just for the top arch. Right? I mean, you don't know, right? So we got to find out. So let's look at, and that jumped ahead a couple screens. So what about the saliva? It's an easy medium to collect. It's simple, it's non-invasive, it's really easy for our patients because saliva is the medium that we're going to use for this particular type of testing. And it's so it's a great choice. The other thing about the saliva that's happening is we're going to be able to start to detect other diseases. And we do that because I also am studying a fellowship in anti-aging medicine through the American Academy of Anti-Aging Medicine, and they use saliva for all kinds of things to detect disease. So we have a lab that's very tied to the dental world that will help us, and we might be able to have some very simple testing that we can screen for other diseases. We have to figure out again how to incorporate that in practice. But Oral DNA is doing that, and they'll have some things available for us in the future to think about. Two things that we typically send to a laboratory. We either send a piece of tissue, a tooth, something that we biopsy. That's a clinical specimen. That goes to that's an anatomic slide. That's an anatomic piece. And then there's other things that we send, like fluids, blood, saliva. So this laboratory is designed and has two sides to it. And we can get a lot of different things, but this is what we're going to focus on right here. We're going to focus on body fluids, and it's the saliva that we're talking about here today. So the mission of the lab is to provide some objectionable data that we can use that's reliable. And then here's the key, and this is what I was talking about this morning with Jeff and Kendra, is that it has to be practical and it has to be useful. We can't collect data just to collect data that we don't use on our patients, so it needs to be useful. So I'm going to talk about for the rest of the lecture, we're going to talk more about the saliva and how I use it for periodontitis. How many were with me on Friday for an hour? How many people? Good. Please ask some questions. I think that if you were in the lecture on Friday, I test every active diseased patient. So this poses the question, why don't I just test everyone? And should I test everyone? I can tell you that the company would love for you to test everyone. The reality is that if I test everyone, it gets confusing sometimes because my patients without disease that have high levels of pathogens, that can be confusing. So you can understand that a patient with no disease could have a microbe that's above threshold, and everybody will be familiar with the test by the time we're done. And so what do we do for that patient? That's confusing. So I decided to keep it safe, and if you're either just getting into this or perfecting your system, I would recommend that you keep it safe as well. Test your diseased patients, because this disease is very much caused by bacteria, and when you test your diseased patients, you will find out what that profile is, and it's the host's disposition and how the environmental and all the other risk factors in their life add up to make them respond to that bacteria in a certain way. So we have to get some other information from the patient to make sense out of the test. And we can use this to prevent disease. We can use it to assist with our disease diagnosis, and we can for sure use it in the management. In Inside Dentistry in I think 2012 and then in 2010, if anybody wants to email me, my email will be on the end. I'm happy to send you some things, but we talked about testing for verifiable results. So the retesting question, when do I retest? You retest when your patient when your treatment has finished and you have zero bleeding and you're confident you have zero bleeding. You retest because you want to see what kind of shift you've had in that microbiological footprint. And everybody has kind of this microbiological fingerprint. And this test is very specific and it's very accurate. The test won't be wrong, so whatever you see on the test, that's what's going on inside your patient's mouth. And so we use it as a measuring stick along the way to determine the success or if we have to tweak our treatment. We used to culture or try to culture the bacteria, but there were some problems with that. Some of these bacteria are anaerobic and they died between the collection of the sample into the petri dish. When you swab a petri plate, everything in the mouth grows. Everything on the sample grows. So we've gone away from the old culture technique, and now we're using the saliva. And I want to make this clear as well because I think this is a big source of confusion. We're not measuring the person's DNA. What they've done is just like on CSI, on crime scene, they've DNA fingerprinted all the bacteria, 13 of the most widely implicated bacteria in gum disease, they DNA fingerprinted them. So all they're looking for is the DNA fingerprint from those 13 bacteria in the saliva sample. They're not looking at your patient's, there's some other tests where they're looking at your patient's genetics, but the MyPeriopath, or the bacteria test that we use for everyday chronic periodontitis, is a test that tests for the DNA from the bacteria. And so that's an important distinction to make. And it wouldn't matter if you dump some other stuff in that vial, although I'm not a proponent of that, but it wouldn't show up because that's not what they're testing for. They're looking for the remnants of these bacteria, and they'll give you a quantifiable concentration and if they're present or not. And that's huge in our retest because we can show patients how we change that profile. And I mentioned it on Friday, and I'll say it again, and this is something that you might want to write down because this is the goal of our therapy. The goal of our therapy is to take your patient from some state of disease that you determine what that is. For me, in my practice, it's a certain number of bleeding points, and we use line bleeding as a way to determine what it is. We take a microbial profile. We treat the patient, and I don't care how you do it. You heard a lot of cool things here at the meeting today. There's things you can take. You can put some medicine in trays with Periprotect. You can do all kinds of ways. You can debride with a scaler. You can add antibiotics. You can, lavage with iodine. You can do a lot of different things to try to control the microbial load. Just when you're done, and you think you're done and you've achieved the ideal endpoint, which is zero bleeding, then just retest. And what you're looking for is either suppression, eradication, or an alteration in the combination of the bacteria. So suppression, eradication, or a change in the combination of the bacteria as it relates to health. Because that's the new health fingerprint, right? That's the new health fingerprint. You know the disease fingerprint, now you have the health fingerprint. You'll see that if you track that over some years and they stay healthy, that health fingerprint, their fingerprint, unless they go back into active disease, will not look like that initial disease presentation. That's really cool when you can show a patient that. The goal, one of the benefits of retesting is to be able to show the patient the change, and it's very cementing for them. When they see a report that's very colorful and has a lot, and it doesn't matter if it only had one bacteria on it. If they were responding to that one bacteria in a negative way that was expressing disease, and then you treated them and you eliminated that pathogen, or you suppressed it, or you changed the combination of pathogens, and they were all of a sudden healthy, and they saw that shift on the report. It validates it validates your treatment. It validates what they're doing at home. It's a very reinforcing tool to use, and it helps you know what's happening because we know that the bacteria always precede bleeding, and I'm talking about in clinical practice, right? This is what we do. This is what we do all the time, and that's important. So the vocabulary. I'm not a scientist, I'm a clinician, and you've already known I have some scientific slides and I've taken this. I want this to be a clinical talk. It's 8 o'clock in the morning on Sunday. You're going to go home and you're going to start working tomorrow. You need to know how to use this test. If you're not using it, you need to struggle with, why should I use it? I don't want it to be a struggle. I want it to be perfectly clear by the end of this next hour and a half. And this is your hour and a half. It's not a company commercial, so I need to know what. If you're having trouble, thank you for the question. Feel free to ask them, and we'll keep us on track. So there's some new vocabulary we're learning, and it all started with the Human Genome Project. We had a beautiful opportunity to start to look at the genetics and the different DNA coding that makes our genes that express proteins that make cells, and what a cool thing for us to be able to learn about what might be wrong in that pathway or what might be altered in that pathway, and we're going to get to a little genetic piece a little bit later. But for diagnostics, there's no question that we can use genetic information to really help us and assist with our diagnosis. And so oral DNA, again, is the best positioned laboratory to provide us this information going forward. The labs do tests for infectious disease, inherited disease, genetic susceptibility, but the test that I'm most passionate about and you have a pamphlet, by the way, on this piece of information on your desk has the MyPerio ID. This is the pathogen, or MyPerio Path. This is the pathogen test, and on the back is the MyPerio ID. That's a genetic susceptibility test that I'll explain a little bit later. So these tests do help us in the management of periodontitis. I think everybody agrees that this, and I mean in the science community, we all agree that it starts with pathogens, and then it's some environmental things that we throw in on top of the pathogens, like whether we smoke, how much sleep we get, what do we eat. All these other behavioral things kick in, and that modifies our ability to either fight off these pathogens or not fight off these pathogens. That creates our immune response. That's the host immune response. It's created by all these things over here. And plus our inherited genetics. You can't change the genetics, but what you can do is your genotype, in other words, what genes you have. In other words, if I have the Alzheimer gene or a heart attack gene, it doesn't have to be my phenotype. It doesn't have to be what happens to me. How can I modify it? I can modify it through modifying my response by changing my lifestyle, changing my diet. I don't think there's a pill that they can make that can create better health effects than lifestyle management. What we put in our bodies, stop supersizing, right? Eat, exercise. That's what we can do. So we have to take this genetic information and we have to figure out how are we going to use it in practice and what are we going to do. And this, in the genetics that I've used the most in practice from the MyPerio ID, because I didn't know how to use this when this first came out. And when I saw patients that had an actual genetic predisposition, whether it's to produce more IL-6, IL-1, whether it's beta-defensin, tumor necrosis factor, all these different cytokines, I still had to say, what am I going to do with it in practice? So, you know, because that's what I would say, oh, Betty, you have excess production of tumor necrosis factor alpha. So, what's that mean? Right? We have to lend some meaning to that. And again, Oral DNA is a great company to help us collect data, like who has that stuff going on, and then they can run some unbelievable mathematics on all these tests. If you think about thousands of people that are getting tested for genetic predisposition, periodontal disease, and they'll start to create some correlations and maybe some patterns will develop, and we'll all be better clinicians because of the work that's being done on our behalf in that arena. But what do you have to do? You have to do what I've been doing for 5 years. You have to develop some kind of policy of how you treat periodontal disease and the information you collect to treat it, and be consistent with it. And don't keep changing a bunch of parts, because you'll never figure out what works and what doesn't work. Create a nice little system that works, that you're getting good results on the test, so you got a post-test, and then tweak it as something new comes along. Don't change 9 parts at one time, because it'll create a lot of confusion. So So pathogens are what I test for the most, that's for sure. And this other genetic piece I use, and what I used to do the most was put patients on low-dose doxycycline as a collagenase inhibitor, right? That's Periostat. I used to use the old Periostat, and so I would inhibit the collagenase. I can tell you that through the American Academy of Anti-Aging Medicine, I'm learning that we can alter the nutrition, we can alter the inflammatory pathway with other essential oils and other different things that we can use, but that's way beyond what we need to know for this lecture. And I think that if you could think of the forest of periodontal disease, and some trees are really tall, and some things are bushes, like little tiny things, and you got to clean out the whole forest, go for the tall trees first. And that's your pathogens. I mean, you got to deal with that, right? You got to deal with pathogens. You might want to know about the genetic susceptibility, because it might help a patient understand why they're the way they are. Have you ever had a patient break down in a chair and say, I've been trying to do everything I possibly can do, and my gums are still shrinking? And I said, well, maybe you have a genetic predisposition. Well, if I do, should I test my children? I've had patients come in and say, I want my children tested. One wanted to test her spouse. I had to kind of talk to her about how genetics works. Her spouse is really not, right? So patients, when they learn that it's not their fault, it's huge. Question?
Well, I was going to ask, if you have a husband and wife, and they both have periodontal disease, and their children, you know, obviously that puts their children at risk. When do you start testing their children so that you can have an idea of what their susceptibility is?
Yeah, it's a great question. It's you have a husband and wife, they have periodontal disease, and they have children, and maybe there's a predisposition. Maybe it's just a bacteria swapping thing going on, right? Because I can tell you, I have husbands and wives with the almost identical profile, bacteria-wise. And I'll have one expressing the disease, like kind of big time, and the other one's not. So we will do some we will recommend, as a matter of fact, I think Monday morning we have the wife of somebody that I consulted with on Thursday before I came out here for a consultation. And he told me in his consultation, well, if Kim has the same thing, we both want to be treated. That's the nicest thing to do. And it's all like caries, right? You treat the family. That's a nice thing to do. But with the children, I would watch for the disease I would watch for them to have any kind of gingivitis. You know, I'd watch for them to at least express something. What I would love to do is I'd love to be able to predict who's going to get disease, and that's the idea behind testing the healthy patient. We do have some pretty good science that says if you have a certain amount of bacteria in your mouth, you're definitely more at risk. I mean, let's face it, if you had a bunch of the wrong kind of bacteria, you're going to be more at risk than if you didn't. Right? If I go home today on the flight that has all the sick people on it, I'm going to be more at risk of getting a cold than I am on the flight with just all the healthy people, right? So they're in an environment where they're going to be more at risk, but I can't tell who's going to get the disease. And we're going to talk about that with HPV testing, because HPV testing, if patients test positive to an HPV test orally, it doesn't mean they have an oral cancer. It means they've been exposed to something that could create an oral cancer, and so we have to watch them a little more carefully. And so these tests help us do that. And I'm in Michigan. Michigan is really close to Canada until recently. And I believe, by the way, Victoria and George are here from Oral DNA. Please be free to talk to George and Victoria as well. You know that they were at the booth. If you were walking through the trade show, you couldn't miss them. They were right on the main floor. But this is all available in Canada now. Is that correct? Everything's available in Canada. But I used to have patients drive from Toronto to Detroit to get HPV tested. And I know Nader's there now in our area, Dearborn and Canton. And but that's how, typically it would be a couple that maybe just got together and they want to know, do they have STDs or do they have an oral cancer risk from HPV? So they come over and get tested, and it's always a happy day when they're both negative. So this data helps me with my diagnosis and my treatment. It really helps me with my management. And there's no question, again, that the quantity is there, and I use it before and after therapy. And I'll show a case. I think it's one of the same ones that I showed on Friday of how we do that. So the MyPeriopath, this is what you have in front of you. And test, don't guess. That is one of the things that I will say as well. People come to me and say, and I used this example on Friday, but they say, Doc, oil pulling's great. I went on the net and I looked at all this stuff about how people are curing all these diseases with oil pulling. And I said, well, if you want to try to oil pull, I'll do a perio chart, photographs, I'll do oral DNA, and you oil pull till your heart's content. And then we'll retest, because that's my metric. Right? So I had someone switch for coconut oil for 3 weeks and 20 minutes a day, spitting it in the garbage. I mean, it's a lot of time, right? Taking some time to just walk around in the morning with coconut oil in your mouth. And then I did the oral DNA, and it didn't move the pathogens for me at all. So I said, well, you might feel better, right? Maybe it's here. Maybe you do feel better. Maybe something else is going on. But if you have periodontal disease and you treat it with coconut oil, get ready to make a denture. It's not going to work. Right? So we use these tests to help us with before and after. And so this report is easy. It's graphic and colorful. It shows you, again, the presence and the combination. And don't be confused by something else. There's only 11 lines there, but we test for 13 bacteria. And the reason why that is because this particular green box right here, they've blended 3 different strains of one bacteria into one measurable. That's the Campanocytophaga line. So this really does represent 13 bacteria, but there's only 11 lines. So that's important to know. And there's good information on the report. The company is here to help you. There's a medical director, where there's people who will help you sort out this stuff. You call me, I'll help you. Sort out what the meaning of the test is. And it talks to you about high-risk pathogens, moderate-risk pathogens, and low-risk pathogens. And I think that these pathogens are not only significant if they're high-risk, and if you've been listening or you were here and you heard Brad and Amy's talk, there's certain bacteria that are being studied in the vascular health world, but all of these are implicated in periodontal disease. And it was some time ago where they were categorized as moderate risk, high risk, low risk. But at University of Michigan, I know one researcher is studying the combination of bacteria and the significance of these getting together. In other words, if you have PM and TF, if you have PM and TF, if you have these two, there's a little synergistic effect, or there could be a synergistic effect, and it might mean more to your treatment. It might be harder to control when you see that on a patient. And I've gained this insight over 5 years of testing, where I can say this is going to be a little bit tougher to control. I can't get into all those details. We could have a much more advanced courses about the interpretation of tests and clinical decisions that we make from that information. But it's very graphic, and it talks about the therapeutic threshold, or it relates them to the therapeutic threshold. And let's talk about that for a second. There is one problem that I have with the test. I've been very vocal about it at the company level, and that is there's two words on the test that are confusing for me and my patients sometimes, and it's normal and abnormal. And in the normal will come back if the pathogens are all under threshold, and abnormal will come back if there's pathogens over threshold. What the threshold represents, there was a ton of research done at the Forsyth Institute, and the threshold value represents that if you have bacteria above these quantities, the relative risk of bone breakdown is higher. Okay, so that basically means if you're loaded up with pathogens above these concentrations, the relative risk of bone breakdown is higher. Now, what I didn't say is your bone's breaking down. There's a difference, right? I said the relative risk is higher. So this patient is in a higher risk category. But for me, I don't use this test to determine if they might break down. I use it to help me treat the disease, right? That's how I use it. So I use it to help me treat the disease. So if I have somebody who has 65 bleeding sites and they don't have a pathogen over threshold, am I going to tell them they're normal?
Question. If a patient has other diseases, cardiovascular disease one, diabetes another, shouldn't that threshold be lower?
Nader says, what if the patient has other diseases like cardiovascular disease or diabetes? Or let's say that we learn that bacteria, these same bacteria are influencing other diseases. Shouldn't that concentration be lower? I don't know, Nader. I don't know what the answer is to that, because I have people who have low levels of AA, they have low levels of other bacteria, and they had 9 5-millimeter pockets. Now they have nothing over 3. There's no bleeding gums. I've seen them repeatedly, and at the 2-year result, I get some pathogens on there, and some pathogens, and I might even get a pathogen over threshold on one of those patients every now and then. I watch them more carefully, but I don't put them back through disinfectant. It's hard for me to recommend disinfection therapy on somebody with 0 bleeding, beautiful gingiva. I mean, that's really hard for me to do. But if there's a medical reason, then I really have to collaborate with my physician, because I think we're getting to that where the physicians are going to say, and this is my concern about the physicians learning this information, we have to put it into proper context for them. Just because there's a pathogen present on the report, I don't know if that gives us the right to say we got to get rid of it, because it's unrealistic to assume that you're going to get a report back that's blank. As a matter of fact, if you get a report back that's all blank, maybe you tested your patient within the window, maybe they were taking antibiotics, maybe your test was goofed up, maybe, heaven forbid, the company made a mistake. I mean, if it doesn't look right or smell right, you would at least ask a question. Call the company and say, what do you think about this? Is this right? Because I haven't seen too many test results come back blank. However, In a more advanced course, I do surgical clearance testing for patients just before they get aortic valves replaced, knees and hips, and I have to decide, what do I want to do for that patient? Do I want to create periodontal stability or a clean therapeutic window for the surgery to happen? Right? Those are two different concepts, a much more advanced concept thinking. But if you think about it, if somebody comes in and says, I'm getting my knee replaced in 3 weeks, and the doctor wants you to sign a note that tells them I'm okay, what are you going to do in your practice? What would you do right now? Would you just look at them and say, yeah, you look okay to me? Now you're signing the chit, right? You're signing the... What do you do? What's that in your practice? Because I'm getting that now. As you start to extend yourself out there as the whole health dentist, you're going to get that. Someone's going to come in, they're going to have an aortic valve replacement scheduled in 3 weeks. And they're going to ask you, the doctor's going to ask you, are you okay to go and have surgery? Is this person okay to go and have surgery? So what do? You're hygienic, and you just walked in, by the way, and the gauze hanging off the napkin chain is all bloody. You tell me what you're going to do. You have to decide. You have to create, what is your criteria for disease, and when do you tell somebody that they're okay or not okay? That's a big responsibility for us in dentistry. So I can use this report to create a nice therapeutic window, because I could take a test, and you need a little bit of time, because there's what's the lead time at the lab to get the test results back? 3 to 5 business days. Maybe sometimes you can expedite it, but you know what the lab doesn't want? 500 people expediting the test results. I mean, that's not fair for the business, right? So we would get the report back, and now I could put them on some antibiotics, prescribe some treatment, and maybe a week before or 2 weeks before their surgery, I could do another report. And if I'm doing that within the time that I've just, within 6 weeks of my disinfective therapy, we significantly alter the pathogen level. So in my practice, we're creating more of an ideal therapeutic window for the surgery. We're not necessarily taking them to periostability. Those are two different things. It takes me in my practice on average almost 4 months to get someone to periostability. That's on average. Some people respond beautifully at 8 weeks or whatever. Other people take longer. Question?
You might have answered my, I missed it, but so we do run it before, when they walk in the door before surgery. If we see elevated numbers, we get concerned, we even have people postpone. But I'm curious, will you not sign off until you've got a clear?
No, I won't sign off until I think they have. I won't sign off until I think they have. I'd like to see the absence of bleeding or the absence of microbes.
But so you will retest. That's what I meant. Will you retest?
Yes. Yes.
Okay.
Yes. And I tell people, the physicians that I work with, they know that I'd prefer a little more lead time, because they're famous for walking in with that right at the last minute. I mean, it's the very last minute, and it really ties your hands. It makes it difficult. Dwayne, do you have a comment on that?
Well, I had a question for you, Doug, and I think this is, and you're probably going to address it, but how do we know the difference between the oral flora, tongue, buccal vestibule, the folds down in the tonsil, as compared to the pathogens that are present in the periodontal pocket? How do we know which of those we're measuring?
Well, we don't know. If you take a saliva sample, you don't know. I mean, I have a denture patient that has had open heart, had some other issues, and I had my denture patient take out his dentures. I had him swish with the dentures in and with the dentures out. I did that for my own edification, so I could show that there's different concentrations of bacteria when you have something for the bacteria to hang on to. And he had high levels of PG. It's hard for me to collect the paper point on that patient, right? That's a tough thing it's really tough. So, I mean, you can do that, but so I think the mouth is a good representative of what's there, but I don't know that. I don't know that, Dwayne. And Dwayne Keller's in the room again with PeriProtect, and these different disinfection modalities that we have all can be effective for our patients, and our patients respond differently. So you have to create a disinfection protocol for your patients. What are you going to use? And I have some patients who, and Dwayne knows, you'll find out if you spend much time with me, I'm very honest about what I do in clinic. I mean, the company takes the risk if they hire me to come up here and talk to you, because I'm not going to tell you something that I don't do or that's not true.
Don't leave us hanging. So what was the difference with and without the denture?
Oh, the bacteria were higher with the denture. Because it's just like, what's the difference if it's a denture or if it's 3 anterior teeth with a bunch of calculus on them, or, right? It's debridement. I mean, you're trying to control the microbial load. So dentures, bacteria hang out on dentures. They hang out all over. And to Dwayne's comment, they're all over the mouth. That's why the chlorine dioxide rinse made by Dr. Richter ProFresh and the other ones here at the company, these are rinses designed to, they're not something that it's not just a gel that you put in the crevice, it's a rinse that you use because there's bacteria in the whole mouth. So this test picks that up and it will tell you that. There's some clinical information on here about interpretation, which is helpful. And one of the things that I'm hopeful about is, and there's also, let's talk about the time frame for testing and retesting. We want to make sure that if we're testing, that we make sure that our patients haven't had any kind of mechanical debridement or they haven't been on antibiotics within 6 weeks of the time you want to test. So you need to ask your patients that to make sure they haven't been on antibiotics because it will affect the test results. Now, periodontal probing is not debridement, right? So it's no problem to probe first and find out if they're bleeding like crazy. That's my patients that then I start to have a disease discussion about. You're bleeding more than I'm comfortable with. It's not normal. We got to do something. And in my practice, it's a MyPeriopath test. And I'll make it simple. Always. I mean, it's easy. It's one of my alwayses. And if they say, and what I might do is, what I said earlier is I might preface that conversation with, I really think you would benefit from disease treatment. Or I might say something like, there's more I can do for you, right? I could do more for you than what we've been doing. I let them know that I could do more for them. And some patients will really want to have the disease taken care of, and other patients, their daughter's getting married next week, and it doesn't fit for them right now. And so we have to find out, if you listen to or if you happen to hear some of the practice consultants, whether it's Gary or whether it was Steve Anderson, we have to find out what the patient's motivation is and what they want from you. So before we go in and do a whole bunch of testing, we have to figure out why they want to be treated. And most of our patients, in a very, very short amount of time, we can find out how they feel about walking around with an active periodontal disease. And some of them are vigilant about getting it taken care of, and others could be so non-concerned that we have to continue to coach that patient and work with them over time to get them to understand the significance of their disease. See, bleeding gums is just a condition. They don't know it's a disability. You have to teach them that. It's just a condition. Because some people say, so, my gums bleed all the time. So we have to have the verbal skills to show them and to teach them in a polite, kind, compassionate way, not entrepreneurial. Kind, compassionate, sincere way that it's a disability and you're concerned for them. And if they trust you, it's game over at that point. They tell me, what do I need to do?
What about mouthwash? Like prior to the
It's nice if they don't. It's nice if they're not rinsing with a Listerine or chlorhexidine or a disinfectant mouthwash. So that's a nice question.
But we find a lot. We do this. We've been doing it for about a year and a half, and we find a lot of patients. They brush really good and fluff really hard, and then they really rinse before they come in.
Yeah, that's okay if they study for their exam. That's no problem.
But it doesn't.
Yeah.
I mean, you can still do the testing.
Yes, I have people who come in too, their gums are all torn up. I go, did you study for this exam? Oh, the last 2 days I've been working like crazy on my teeth. I say, well, it shows. You're killing me. So how about the rest of the day, right? How about the rest of the time? So, no, it's an important thing because we did get into a jam with some of the periodontal therapists where they were having patients pre-rinse with chlorhexidine or something. Please take the periodontal charting data first. Why do we do that? We do that to prevent aerosol. We do that to make a cleaner environment for us, safer for them. Take the periodontal chart first because it's the backbone of your diagnosis, right? You got to do the periodontal chart first. So do that before you have them rinse with anything, so you don't miss the opportunity. I would also tell you that disease, oftentimes, the patient's coming in and what they expect is to get their teeth cleaned. That's why they came to you. They're getting their teeth cleaned. So what do you have to do? That patient, now all of a sudden you discover a lot of bleeding. And now you want to collect some data. So what happens in our practice is we have to let that patient know that they're not going to get their teeth cleaned that day. So that's why we have to have a little brief discussion. Hey, you're bleeding way more than normal. I'm so not comfortable with this. Not only to mention that, this has been the 3rd consecutive appointment that it's been like this. And you know, you went home and you were going to try a water pick and you were going to do some other things, and whatever you were trying or whatever's happening, it's just not working. We could do more for you, but I need to know what's driving this infection. It's usually bacteria. I'd love to take a test. It costs X amount of dollars. I don't care if you cover your cost. I don't care if you give it away. It's an inexpensive test. It's 120 bucks, and you will get it back. And I know your therapy is more than that. Build it into the therapy. I could do it any different way. Charge a lot for it. Do what you want. But we have to collect data. The patient's going to say, you know, my daughter's getting married on Saturday. I really want my teeth cleaned. That's what I'm here for today. Fine. But here's what they don't get to do. They don't get to come back in 6 more months. It's like, if you want me to clean your teeth and you want to go to your daughter's wedding, that's great, but I need to see you back like in 6 weeks or, 6 weeks because we disrupted the bacteria, 6 or 7 weeks, and then let's address this. Is that going to be a better time for you? And if they say yes, then we do that. So I don't send them out mad. Oh, they collected, $200 worth of data, and now I can't get my teeth cleaned, and right. So we have to make sure that it's okay for us for that appointment to turn into a data gathering appointment, and then we bring them back for a treatment consultation. All right. So that's how we would handle that. So that's a good point. Krista? Yeah, that's a little bit more of a loaded question, and we can do that, and we'll hang around and do that, but in the interest of time, because the disinfection protocol, and if somebody emails me, I can write out what I do. But look, I don't want to avoid the question. I just want to make sure we get to it. So here's what I was talking about earlier, is that the historical data or the supplemental data that you fill out on the oral DNA form, and you'll see on the box on the test requisition, it's going to ask you some of the behavioral things that the patient does. As diabetes, do they smoke? And the whole idea is we're starting to put together some statistical meaning of some of these environmental risk factors. And this company is really well poised to collect that data. Because if your patients smoke, that's probably the biggest, right now, it's the biggest issue with the difficulty in controlling periodontal disease, smoking. But there will be other things that will become more significant as we supply the company with data. So that's what we want to do. And I don't need to tell everybody that smoking is a big issue, right? And it's predictive of future bone loss. And we want to try to get people to stop smoking. The idea behind this slide is when they start getting large numbers of samples and they see patterns, this company is going to help us gain valuable insight about what's significant and what's not significant. That's going to be kind of cool. So again, this is objective. That's another reason why I like about it, because I'll hear people say, like the oil pulling, they'll say, oh yeah, my patient oil pulled, and they looked a lot better. They looked a lot better. Well, I don't diagnose periodontal disease with my eyes. It's got to be a probe, and then it's got to be a bacteria sample. So I don't know what they looked a lot better means, but that doesn't work for me. And I'm going to ask you, as an oral health leader in your community, that shouldn't work for you either. You should not diagnose periodontal disease with your eyes, because you can't see it. You can't see it. You got to pick up a probe. And people ask me which probe, right? The Florida probe was here. You know which probe? The one you use. I don't care. Use a ruler if you can get it in there. I mean, use whatever you want. Just measure, right? So, and here's the observed findings by a clinician right now. It's family history of periodontal disease, pregnant, nursing, immunosuppressed, diabetes, cardiovascular disease. If you see a change on this panel in the test, it's because maybe we're learning as the new science emerges that there's something else we should be looking at. And so that's why that's on there. Laboratory tests are quantifiable and reproducible. I can tell you that's absolutely true. You're not going to get errors in the sample. The sophistication of the equipment is unbelievable, and it's accurate. So Bill, and this is the same case that I showed on Friday if you were there, but anyways, Bill comes in, he doesn't fill out his health history complete, and I started asking him questions because that I'm very aware of the 25 or 30 other conditions that put them at risk for cardiovascular disease. And so I want to know, Bill has 3 of them. He said he was perfectly fine, but he has 3 of them. He says he was getting his, I asked him, I said, Bill, you have some redness on your face. What's up with that? He goes, oh yeah, I go to University of Michigan and I get some laser treatment for rosacea. Well, that's an autoimmune disease, right? Rosacea. And then he said, I smoke a pack a day. And he had a little bit of abdominal fat, so that's inflammatory. Smoking's a bad deal. So I knew Bill had some other medical risks. And we're not going to go down Bill's medical history. But and the reason why he didn't fill out his health information was he didn't want his life insurance policy to, to his life insurance premiums to go up. So people don't do things for a lot of reasons, and so I have to get that information out from him. So Bill has very active disease, and here's his profile. So when I see bleeding, and these are line bleeding points on the periodontal chart, and if you want to look up the old papilla bleeding index, you can learn about point bleeding, line bleeding, triangular bleeding, and droplet bleeding. It's line bleeding, recorded by our therapist, and then when we see a certain amount of bleeding, we're taking a test. And this test comes back and it gives us the antibiotic profile, the antibiotic fingerprint, the microbial fingerprint, the microbial profile, excuse me, I said antibiotic, the microbial fingerprint. And with that fingerprint comes some recommended antibiotics if you want to add those to assist with treatment. And again, then your treatment protocol. And Krista, we're going to talk about that hopefully before the end. It becomes a signature, kind of like a bacterial signature, a microbial signature, and it carries on with them. And again, you'll see change in that signature, and then you can remeasure it out 2 years, and you'll continue to see stability in that signature if the patient's stable. It's very interesting. And so it does help you determine how effective your therapy is. Here's 2 examples. The other thing that the oral DNA report does is it puts a comparison on against their last. Is it their very last MPP test? Because I take serial MPP tests. I do it about every 2 years. And when I say MPP, I mean my periopath, so it's that test. So this is a 37-year-old female, had some antibiotics. Sometimes they might go on antibiotics and one of these pathogens might not move. I don't necessarily know what that means. I don't know if they're resistant to the antibiotic. I don't know if they didn't take it all. I mean, I don't really know what that means. But we know, again, there can be some stubborn combinations of bacteria, and you might have to do some more adjunctive therapy. You know, maybe you put them on some trays. Maybe you do some other things for them. This was another patient that didn't do anything in between, basically just more home care. I can tell you the patients that have periodontal disease can't brush it away. They typically can't brush it away. So I don't mind if they come in and say, Doc, I really want to do a better job at home. I haven't been doing anything. I need to, because I talk to patients, you have to clean the tops of the teeth and you have to clean in between the teeth. And gum disease is an in between the tooth disease, typically of the molars. So if they come 30 minutes late, I don't cancel their appointment and burn an hour of clinic time. I put them in the chair and I tell the hygienist, go for the molars. Forget the rest of it. I know that big bridge of calculus on lower anteriors is so appealing, but just go for the molars, right? Because that's where the disease is happening. And do the best you can in a half hour, because that's their fault, not your fault that they're late. And so treat them best you can and polish the teeth and let them go. But you can't brush it away. And you'll see from these tests that's true. So Bill was treated to very stable disease, and this is an idea of what you get. Here's his pre-test results, and here's his post-test results. We do this time and time and time again. We have very good test results. And I think the company can start to see patterns in your testing. If you're getting poor test results, look at your disinfection protocol. Something's not comprehensive enough. It's not robust enough. Something's not right. Go ahead.
When I retest a lot, the second time I get over the threshold bacteria in another that wasn't visible in the first time.
Yeah, the earlier words were suppression, eradication, or a combination in the bacteria profile as it relates to health. Happens to me too, because that's what happens. Sometimes you take out some pathogenic bacteria, some highly pathogenic bacteria, and another one might pop up. It might invade its living space. That's kind of how it happens. I mean, there's a lot we don't know about how the oral balance happens. And so you might see another one pop up or creep up. But what if now that patient has zero bleeding, no pockets over 4, they look like beautiful? I would just I'd have one eye open, right? They got one bacteria over threshold, but I probably wouldn't put them through anything else. I'd watch them really closely over the next year, and I would see if they disease reactivated, I'd test them again. But I wouldn't get too crazy about that, right? Especially if the clinical was good. Yeah, that's how I handle that. Because then you're chasing a bar on a test result, and that's hard. It doesn't make sense. This is David. He's 66. This is the guy that has all the stuff, right? The double knee replacement, the osteoarthritis, his heart disease, coronary bypass. I mean, he already has disease. He's loaded up with issues. He's got a lot going on. And heavy bleeding, AAP4. Again, I need why do I test? I test to be assisted in my treatment planning. That's why I'm testing. I want it assists me to make treatment planning decisions. And again, his risk modifiers are huge. He already has heart disease. He has the double knee. You know, he's a high-risk guy. So this is the last person I want walking around in my practice, you know, with this disease process going on. So I told him he really, we need to collect other information for him. And so we did do that. Here's the path test. And again, but this was a very old one. It used to be in a vertical format. The test has since changed, but the idea is the same. You can see the colored pathogen concentration. And here's his pre-treatment chart. Here's his post-treatment chart. Fantastic number. And in the early days, I was testing before I got the absence of bleeding. And that's a mistake. That hurt me in practice because I would get reports back with pathogens still pretty present. And we just made a decision in our practice that until they have zero bleeding, I'm not pulling out the retest card again. I got to work with them. So I see them every 8 weeks, 2 months, 3 months is too long. Bring them back more frequently so that you can bring them, just as long as it's more than 6 weeks so you could test them again. Bring them back more frequently until they're not bleeding. And then retest. If you start to test them while they're still bleeding, you're going to be maybe disappointed. So that's going to be one of the first questions. If you call me and say, my post-test results are terrible, I'm going to say, what was your criteria for post-testing? What did you see? What did you do? Oh, it looked better. Forget that. You wasted some money and the patient's time and your time. Wait until they're stable, then retest them. So at this time, and for us it was, we decided, you know, 4 or fewer sites, we would let that go. But I prefer zero bleeding. But I'll test the patient. And at this time we tested David with 1 site of bleeding, and he had all these risk modifiers. And here's his post-test results. So this is very nice post-test, and we had a reduction from 44 bleeding sites to 1. That's nice goal of therapy. A lot of pocket reduction as well. And we had changed behavior from him at home. He was doing a beautiful job at home. And here's what happened. So here's his pre-test. Here's his 2-year profile. Can you still see how different that is than this? But you can see that PMs may be creeping back. There's a little bit of PI and there's a little bit of TF. I'm not worried about that. He's still stable. He's still stable. But this is how this might change. This is 2 years post-treatment with just periodontal maintenance. He hasn't had any other therapy. It's very stable. And this was his initial disease stability chart. So I will compare the 2-year against this and say, how are we doing? And so David asked me, how's the test look? And I said, it looks very good. Your clinical signs are still beautiful. The report shows you got a few bacteria creeping back, but it's not, keep up the good work. You're doing a great job. And I wouldn't retest him. I'll test him at 4 years, which I've done, by the way, and it's very similar. But he's, unless the disease reactivates for him, I wouldn't retest him again to put him into active therapy. I'm only retesting him for maintenance. And I charge a little less fee for retesting him for maintenance because it's really been good information for me to learn how this microbial profile stays down over time. It's very cool. So the bacteria are only part of the story. The other thing is this genetic piece. And what happens when the patient has a genetic predisposition to produce a greater inflammatory reaction? That's really what this is, right? All these things, this data that we collect about the genetics, what it's doing, and for this it's IL-1/6. If there's a mutation in the IL-1/6 gene, then this patient can overproduce some inflammatory mediators. That's basically what this means. And there's multiple genetic markers, a lot of them actually. And I'm going to introduce you to a test that's going to be available soon that actually gives you a panel of these things, not just one. Because right now the companies that we've been dealing with just typically give us one genetic variant, and now we can have more. But I want you just to get the idea how we would use this and what it would be. So I can tell you that A direct heritable form of periodontal disease is very rare. As a matter of fact, I'm not a scientist. I don't know of one. I'm sure there's some odd syndromes where if the mom and dad had this or one of the parents had this, that the kid would get it, but it's very rare. Most of these diseases don't come because you inherit it from your parents. What you inherit is a gene that might upregulate one of these inflammatory cytokines. So it doesn't give you the disease, it gives you disease susceptibility. It increases your susceptibility. I happen to be PST positive, which means I have a variation of the interleukin-1 gene, and I'm an overproducer of IL-1. And that could be to any inflammatory issue. So if I had arthritis or if I had other issues, I could mount a greater immune response to that insult because I've been tested genetically. And this there's going to be a panel available for your patients. So periodontal disease does run in families, but it's the susceptibility to periodontal disease. Just because the parent had it doesn't mean a kid's going to get it. And just because they have a genetic predisposition doesn't mean they're going to get it. But it could really help them understand why they have it. Right? So if you have a patient who really wants to know or really wants to know about their family, the genetic piece can help them determine why they have it, why they've been working so hard at it. And we do have that, we do have people who want to know that information. This is a family right here. This is the mom. These three siblings from the mom are in their late 40s and early 50s. In all of them, none of them have ever had active periodontal therapy, and all of them have some signs of periodontal destruction. And so they have, and I can tell you one of these patients, not too long after this slide was taken, had an active disease burst, and we put him through treatment. But this patient, these three people could look like this person over time. This person had an incredible disease burst at some point in her life. I don't know when it was. She's been stable in my practice for 15 years. 2-month recare for 15 years. Look at those root surfaces. We're not damaging them with scalers. This is, by the way, if this walks into your practice as a new patient, that's not a prophy. Right? That's hard. That's the problem with our system. That's not a prophy. This is stable periodontal disease. And here's the deal. This whole family is PST positive. So she says, I always brush my teeth. I don't know what happened to my teeth. Well, this helped explain how her teeth got 50% longer. Right? And what her children might go through should they not have routine regular care. So I might say to this patient, I don't know wherever you are in the world, but you really will benefit from some routine, regular professional care. I say that in the consultation too. It's also a nice way to validate to the patient that they don't have to just have care in your office, but I don't care if they move to Canton and they see Nader. I say wherever you are, Nader and I are not too far from each other. I say wherever you are in the world, you need to have a little more attention paid to your teeth. Because I have some people that come in my practice, they haven't been in 10 years. They don't have anything going on. Not many, right? But those are some lucky people. So you've heard the word SNP. That's a big popular word now, SNIP. That's a single nucleotide polymorphism. And it's when these letters all don't line up. This is what they find out in the testing laboratory. This is how they do this. And these SNPs code for proteins, code for genes that make proteins that create cells. And if there's some variation in these things, then it can create a susceptibility. So that's really what they're looking for. So when you talk about genetics, it's really maybe it'll come clear here on the next slide. This little apparatus is no longer working, so that's good. Challenges all day. So what happens is these SNPs, depending upon where they are in the gene sequence, they may either upregulate something or they may downregulate something, but they have an effect. And the scientists will help us figure out on our reports what that effect is. So all you need to know is that all I wanted you to get out of this is that they're testing for a variation in the makeup of our DNA that makes us susceptible to disease. That's a real Detroit way of saying this, right? So the Perio ID, it tests for this SNP in the IL-6 protein, and again, it's a mediator of inflammatory response to bacterial overgrowth. And if they overproduce it, they might mount a better or a more aggressive response. That's what this is about. And the results are high, intermediate, or low risk. So it helps the patient maybe understand why they have disease. Now what we have to figure out in practice is, what do we do about it? What do we do about it? Do we put them on Periostat? Do we give them fish oil? Do we give them curcumin? Do we give them some other anti-inflammatory? Do we increase their vitamin D? What do we do with that? That science is playing out, because there are quite a few things that we can do from a nutraceutical standpoint to support our patients' periodontal health. Do we put them on nitric oxide? What do we do? I don't know. I don't know the answer to all those, and I don't bombard my patients. One of the biggest complaints, I don't know if you have holistic physicians in your community, but one of the biggest complaints and one of the things I'm running into, patients go to a holistic physician, they come back, I'm on 30 supplements. I love to do that in the morning, before or after the pancakes. When do you do that? That's hard for them. Because why do do you think really God made this system that hard to manage? You got to be 30 supplements to stay alive or to be healthy? Can we get it from our food? Can we do something different? Chances are we can, right? So I have patients do micro and macronutrient testing if I see somebody has a significant nutritional imbalance. I don't just start giving them stuff, but we have to figure that out. I don't want to get off track, but we have to start figuring out what can we do to modulate the host's response to some of the bacteria. And I can tell you there's things that we can do, and it'll come down the road, and I'll help you with the scientists figure that out, and then I'll figure out how to put it in practice, and we'll have to figure out when do we do it and when don't we do it. We'll help you with that. Because here's the deal. It looks confusing, right? That's because it is. It is confusing, right? We're clinicians. We're not scientists, so we don't look at all these molecular pathways. But wouldn't it be cool if we could all of a sudden maybe group a bunch of these things together and get more information from one test? And then maybe the most important information, how do we decide that? That's decided by the science lab and testing companies. Because a lot of these different inflammatory mediators can have genetic twists. So this is what happens in periodontitis, and I can tell you there's multiple things going on that create the host immune response to this disease. And as we figure these out, some of these things are going to move up and down on the list of importance. Right? Before, just this year, before what's coming out, all we had was IL-1. Now we have IL-1 and IL-6, and soon we're going to have a lot more than that. But here's what I don't know. I don't know if one of these is a bush or a tree in the world of periodontal susceptibility. I don't really know that yet. But it'd be nice to know the information, so the companies are going to help us sort that out. And then what I need to be able to do is make some clinical sense out of that piece and help the patient understand what's going on. So multiple markers are going to be better than just one or two markers. And we know, just like the combination of bacteria, we don't necessarily know if it's additive, if there's a multiplier, or if it's a positive or negative effect. And I think you know what I mean, right? If somebody has a genetic SNP, maybe one of those SNPs could be helpful. I mean, maybe it could do something that's better. We just don't know. So the company will help us. But look at 70 differing gene markers have been demonstrated to be associative in chronic periodontitis. That's a lot. That's a lot. So what's happening now, if you look at this list, what the company has done and what the company's going to come out with, is it possible to test for a lot of these at one time? It is. And this is hopefully going to be on the horizon, because we know some of these gene markers are totally independent of each other. Some of them are dependent on each other, and some of them are interdependent. And the company will help us figure out, what that is and how it correlates to clinical reality. Next-gen sequencing is, again, oral DNA. This is going to be the new term that you hear. It's called next-gen sequencing. And it's the ability to have what used to take a room full of computers to figure out in the human genome It can now be done in a testing laboratory like oral DNA, and they can gain valuable information about multiple pieces of gene material all at the same time and what it means to us. And that's what oral DNA is poised to do. Do you want to say anything, you or Victoria, about next-gen sequencing or what that might mean for us in the world of genetics? And
yeah, I'm directly the one with oral DNA lab. Thanks, Doug. With PCR, every reaction, every analyte requires an investment of the cost and has the time associated with it. With next-generation sequencing, it allows us to take the same sample and get many answers for much lower cost. So if a single analyte would have cost $117 and you want to have 100 answers, obviously that's not economical. But using next generation sequencing, maybe for $200 or $300, you might be able to get those 20 or 50 or 100 or 1,000 answers from the same sample. The throughput time is about the same as PCR. We know that we can sequence almost the entire human genome for $1,000 right now. So the clinical opportunity is to try to drive the cost down and get many more answers. So if the puzzle that's presented by the inflammatory response is many markers, you want to get as many as possible and try to make sense out of them. The reason it hasn't been done at this point is because it's cost prohibitive. So what we've tried to do is take out the entire list that Doug just showed you, a very large candidate list, and whittle it down to those that are clinically important and rank them and then determine their relationship. But with the same salivary sample, you can sequence it to get many, many more answers. Right now, if you're getting a maternal screen, you might get 1,000 different genetic answers that are helpful to the one that's about that baby. You want to bring that same power to dentistry.
And that's awesome. And I would ask you guys, and I would beg you guys, because you know what we want as clinicians, make it affordable for us, and then help us decide the meaning. That's what I would ask the people who are doing that stuff, because when I use the information, I would like to have some of that information. It helps my patients understand their disease process. It's helpful, but I have to be sensitive to when do I do it and when don't I do it. And you know you have patients in your practice that pretty much put their MasterCard down and say, Doc, whatever you need to do, I'm up for it. And then you have other people who are coming in and saying, I don't want an exam, don't come and look at me, matter of fact, don't probe my teeth, don't do anything. Just take that rubber cup, right, and just clean my teeth and get me out of here. I have people who hide around the corner to see if I'm in the room. You know, if I'm around, if I'm not around, then they'll come in or they'll run out. You know, they want to avoid the exam. So I would go and I would say something like, I know you really want to avoid the exam. Tell me a little bit more about what that is. What's bothering you about that? Is it I'm going to find something? I'm not looking for stuff in my practice. I'm looking for a reason not to treat people in my practice, not to treat people. It's refreshing. They like that. So anyways, but that's a little off track. So here we go. It's coming soon. My genetic periodontal signature, and it's a panel of biomarkers. And I don't want to get into the biomarkers. I don't want to even get into so significant. I think you know the meaning already. We talked about that. All I can tell you is that this company is well poised to take us down this road in a legitimate, judicious way so that we can employ this information for the better treatment of our patients. And you can, I don't know what's available. Really not much is available now for people to start looking at this, right? But it's just be on the lookout for it and know that the company can provide it and they can help you with that. It's very unique to each patient, and it will help in the planning, especially as we learn more about the significance of some of these. And it's interesting to me because when I'm studying at the American Academy of Anti-Aging Medicine, I am seeing some of the same genetic SNPs being looked at for other things as well. So I think the companies will help us sort that out in the future, and I'll help you sort it out as a clinician. So again, future testing in the genetic world is great. You know, it's this triangle that we can never get away from. And I've decided to be most effective in my practice, I take care of this big time. I mean, I really work hard on the pathogen load, and I then use this other information and I try to modify this. I don't really harp on somebody. You know, they know that I know they shouldn't smoke. I coach them every time on the significance of not smoking. As a matter of fact, I would use that same analogy. David Mines, anybody heard David Mines speak before? David Mines is a nutritionist out of Florida, a real funny guy. And he would say that forest analogy, the forest of nutrition. You know, fat's a real tall tree, sugar's a pretty tall tree, You know, maybe beta carotene is a smaller tree. Maybe some other things are smaller trees. So he said, when you're trying to manage the forest of nutrition and figuring out what you should eat and don't eat, if you smoke, just go wild. The whole forest is on fire. Don't worry about it, right? I mean, so we know certain things cause real trouble for us. And so when I have somebody come in and they have this real huge issue with smoking or some kind of thing like that, we coach them, but we have to pick off the things that are the most important. And here's what I pick off right here, because I know without this, not much is going on. Now, in my smokers, that's going to be hard to control. My diabetics, that's going to be hard to control. My people with other issues or maybe genetic issues, that's going to be my I1 positive patients, that's going to be harder to control because they mount a more aggressive inflammatory response. But it just lets me know that I need to be more aggressive or more, you know, or tighter with the recare, tighter with the treatment. That's how we do that. How about HPV? This is another screening tool. And this is a screening tool, and you know we're vaccinating a lot of our daughters and now maybe even some of our sons for HPV. I think in my generation, 52, they, you know, 1 in 50 or 1 in 40 had the disease. Now it's maybe 1 in 5 or 4, you know, with our children. So, I mean, this is going around. Sexually transmitted. They're exchanging body fluids. Both at a way younger age than you would think it's appropriate to exchange body fluids, and in the senior population. I think they're having a ball in those old folks' homes. So I guess something to look forward to when you get there. It's HPV. So anyways, what this is and what you can do with this is if you either have a high risk patient, or you have somebody who has concern about oral cancer, which I couldn't be more serious about screening for, and I do use an enhanced methodology to screen for oral cancer. So I don't care if it's oral ID, Identify, Velscope, whatever you like to use. My patients know that I'm looking a little bit harder than average, and I also have this available for them. If I see papillomaviruses or something else growing in there, I'd like to know if they have been exposed to one of the most virulent strains of HPV. So I would offer this, and I use this occasionally. It hasn't been a big driver of my practice, but I have some people, again, like I said, that drive to me for it. So patients are, you know, it should be part of the conversation, but you'll find the patients who are sensitive to it and want this, they'll ask you for it, but you need to let them know it's available.
I've been torn about this because, as I understand it, you could have positive and then they can heal and then it's not positive.
Correct.
So I don't understand what I'm gaining by finding a positive. What do I do with that?
Well, what you do with a positive test result, number one is, especially if they have a lesion, if you have a positive test result, then I definitely want to biopsy the lesion, right? If there's a pedunculated lesion or papilloma, any kind of lesion, I definitely, because HPV is prevalent in a lot of the lesions, but there's a couple strains that can be more aggressive, and it would be nice to know, because I think what we would do is we would just examine the patient maybe more frequently and watch more closely. So I think that's what it is. But yes, your body can have the ability to have the virus be present at one time and then not be present, you know, basically eliminate it. So I think that it's a piece of the puzzle that might help them become more aware that they need to be looked at more frequently. I typically do oral cancer exams in the practice every year at least. We do it at each periodic recare. I kind of, you know, and I know there is a separate oral cancer screening code. I think the significance of the oral cancer exam, I'd like to see it moved away from the end of the hygiene appointment, and it should be maybe a separate, you know, kind of exam, but it's, again, another appointment, it takes time. So we're struggling with that whole piece. But yeah, the oral cancer is and I do a lot of oral cancer exams and don't find cancer. And it's odd to me because I think, look at the time and money I spend doing oral cancer exams and I don't find cancer. But I have a bunch of my patients with periodontal disease and I don't detect it. I just let it walk in and out of the practice. Why do we do that? I mean, and that's the disease you can have a huge impact on. Now, I'll tell you, you can have a huge impact on oral cancer too. So my patients that run out that don't want that oral cancer exam, I would say something like, you know, Joe, I don't really care if you lose your teeth. You can still live without teeth. But if you have oral cancer and have to cut your tongue out, that's a bad day. that's a bad deal, right? So I mean, oral cancer will kill you. And most people, the survival rates aren't that great by the time we see it. So it would really be nice to be able to detect it earlier. So if we have something that tells us you've been exposed to something that might put you more at risk, it might be a good idea to look more closely, look more often. I mean, you have to decide in practice how you want to do that. It depends on their lifestyle. And again, these tests aren't making decisions for us. They're giving us information so we can make decisions. You're the doctor. So that's why we have to prudently decide how we're going to use this information in practice. And so I'm just sharing with you as honest as I can what I do. And I know other people who they want to test every patient, and this is a bigger platform of their practice. For me, I use it as needed based on the patient's wants and desires, and then I have to sort it out once I get the test results back. And I have had a positive test result on a patient. Most of them come back negative, but I have had a positive test result. So the HPV in cancers is definitely unquestioned. There's a lot going on with the HPV and oral cancers. The oral cancers and the things that I detect in my practice are relatively small. These are not my clinical photos. The things I see are really small. I would have no problem seeing this, and really what we're trying to do with our ability to do this testing is either detect these diseases before it presents, or detect them much earlier in a subclinical, and I would call it subclinical when they're not having as big as an effect on us. And isn't that what Brad and Amy are trying to do? Dr. Bale and Dr. Doneen are trying to do with heart disease management. They're trying to detect it before it becomes clinically obvious. What's clinically obvious? It's a heart attack or a stroke or chest pain or faintness of breath or dizziness. It's some other kind of symptom. We're trying to detect these diseases earlier, treat them sooner, because it's easier. It saves us big dollars down the road. If we wait until it's late, then it's a problem. So we're trying to do the same thing with oral cancer. We just have to make sense out of what tools are we going to use and how are we going to implement them. So this is the positive strains, 16 and 18. I think there's over 50 strains that this test is actually looking for, but it'll let you know what's there and what strain's there, and then you'll have to get guidance from the company. And Dr. McLennan is the medical director of the company, and HPV is one of his passionate life's work. And so if you speak with Dr. McLennan, you'll be overwhelmed with, and he'll help you with the significance of this. So oral cancer, right now, this is pretty much how it looks in my office. I'm doing a dental exam. If I see something, or if they want it, they ask me for it, I test, and if it's negative, it's just routine follow-up. But if it's positive, then I'm either looking at, is there something present that I have to cut on? Then it goes to the anatomy part of the laboratory testing, where they actually look at a tissue specimen, and then I would do a rinse. And so we recently did this with a patient where we rinsed. She came back positive. She had a tissue lesion. We sent her to an oral surgeon. They biopsied the lesion. They sent it in for tissue specimen testing, and it was negative for HPV. And so that was a good thing. So that lesion was not the HPV, that lesion was not, HPV was not responsible for that lesion. It came back as some abnormal epithelium, but it was not an issue. And then we have to do a consultation. Obviously, and this is where we get oral surgeons involved. I don't recommend taking papillomas off with lasers, so be careful if you're doing that. That plume of vapor, I think you can have some problems with that, so be careful. And so I rely on oral surgeons to help me take those lesions off. So again, gene testing, it can help us with some of the information, and it can help us predict and provide sense and make common sense out of some of these disease entities for people. But there's no question that the pathogen test is huge for us, and retesting for me has been a significant piece of my practice. And the genetic markers, I've often wanted them later in the treatment process, and I wish it was easier, less expensive. I wish it was easier for me to get that data on more people, because more times than not, if I have a refractory case, if I have somebody I'm having a hard time controlling the pathogens on, I would love to know that genetic piece. You know, I'm looking for that genetic piece, and many times I just wish I would have collected it in the beginning. So we'll have to see what the test costs and then how to make sense of it. But again, I'll help you in that regard. So the mission of AOSH, I think everybody knows, we are trying to get for dentists and physicians objective, reliable, actionable data. That's what we want to use. I don't want to do a bunch of things in my practice that I can't use clinically and that I can't make it work. So that's a big issue. And again, this lecture's previewed this, and there's a lot of other things that we could go into and talk about. So oral DNA provides my periopath, soon my periogenetic signature, which I think is going to be much more robust than the current perio ID. This is something that they're also doing. It's how our bodies react to certain drugs and some other things that we have, but stay tuned for the DNA drug map. That's another piece of valuable information that you might use. And then the HPV piece. So let me take, are we totally out of time? We're right there. Anybody can email me for the disinfection protocol slide, but let me go through it really quickly. I mechanically debride the patients. First, I have a test, so I know what I'm going after. I mechanically debride the patients, Cavitron, piezo, scalar, laser, whatever you want to do for debridement, I don't care. I debride the patients physically. I lavage the sulci with a 23 gauge side port cannula and CTX4 rinse, which comes from the Carry-Free company. It's a bleach-based rinse. Put a Reston in any pockets greater than or equal to 5 millimeters. Put them on a systemic antibiotic based on the oral DNA report. I put them on CTX4 for 2 months after treatment, 8 weeks after treatment, 1 minute, twice a day. They have a water pick. I give them a couple options for enhancing the effectiveness of the water pick with either bleach or grapefruit seed extract. They have a power toothbrush. They have a high fluoride paste for protected root surfaces and the fluoride effect. And they have great education. And all that stuff is a basic protocol that I use that makes a big difference in the health of my patients. And if you want to alter that, go for it. Just do me a favor. Test them ahead of time. Test them after. And when you're getting really consistent best test results, when the company calls you and says, "What are you doing? Your test results are fantastic," come and stand up here with me and share it with the world, because we're all trying to do different things and there's a lot of confusion. And so let's do something. Go ahead.
Debate about using the antibiotic at the end of
No, during scaling and replanning. Told them about disinfection protocol. Right? They have an infection. So that's how we treat it. Thank you guys so much, okay? I'll be hanging around. There's some stuff on the, there's some stuff for my place back here, and I'll move this conversation to the hallway if anybody wants to continue to have it. Okay? Thank you.